and its application in anesthesia practice. And Vijay sir is HOD Cardiac Anesthesia, KMCT Medical College. He'll be speaking in a topic called Silver Tsunami. And as we all know, they are very excellent orators, and let's hope for a wonderful academic evening from both of them. Rajesh sir, over to you for the class.
Thank you, Dr. Fijil and Dr. Priyanka for the invitation to participate in this ISA Calicut City branch meeting after a gap. And thank you, Dr. Nazar and Dr. Binil for the guidance on the city branch. And let me start sharing my slides. Hope it will work. Is it coming?
Yeah, it's clear.
Thank you. So let me go to the topic. Dr. Priyanka has asked me to present a topic, and with a short notice, what I thought is we could do something which is likely to be a practice in the next decennium. So I will start with a few case histories. So there's a 50-year-old man who's admitted for pyelolithotomy, and he's noted to be in good general condition, and anesthesia was, as usual, induced with the propofol, fentanyl, and vecuronium as muscle relaxant, all standard doses, and he was maintained on oxygen, air, and isoflurane. And everything was fine. Till 1 hour into the procedure, he was observed to be sweating profusely with increasing entered carbon dioxide and temperature of 38.5 degrees centigrade. Hope from the case history, its diagnosis is very clear. The patient was going for a malignant hyperthermia. And second history case is a scenario is a 17-year-old female for tonsillectomy. Again, there was no significant medical or surgical histories. Anesthesia was induced with the propofol and tracheal intubation facilitated by succinyl choline. Patient maintained on oxygen, air, and sevoflurane, and atracurium was used as a muscle relaxant. And there was no spontaneous effort even 1 hour after the procedure, which was confirmed by neuromuscular monitor. Hope in this case also the diagnosis is very clear, and it's choline apnea, prolonged apnea following succinyl choline muscle relaxant. So in both scenarios, the anesthetist was unprepared. It was not prepared for this eventuality. But these are occasional events. If you search the net, these are unusual events. In fact, it's not unusual in medicine to go like always. Medicine is not a pure mathematics. 2 + 2 = 4 can happen in mathematics, but it can go wrong depending on so many situations in medicine. It was William Oster in 1892 observed that if it were not for great variability among individuals, medicine might as well be science and not an art. But let us see how things are going now. With the precision diagnosis, if William Osler, if he is alive, if he wants to change his statement. So individual variability in drug action is a norm in anesthetic practice. In fact, for an astute anesthesiologist, it is something which he lives on, and it is something which he tackles in his everyday life, and is always prepared to deal with these outliers. And you can see that a patient, all this group of patients was administered the same drug, and some patients developed serious side effects, some did not have any response, but a good number of patients will have a desired response. So what is whom to blame on this unexpected action? It is the genetic makeup of the individual. And there are two terminologies like pharmacogenetics and pharmacogenomics. If you search the literature, you can see that both the terminologies are used interchangeably, and more or less they are of the same meaning. But In fact, there is a slight difference. Pharmacogenomics is an inherited variation in drug metabolism and response. Usually, it is due to single nucleotide polymorphism. That is an inherited variation in a single gene. But pharmacogenomics encompasses the study of many different genes that determines the drug behavior, either due to drug metabolism, action of the drug on the receptors, or the action drug elimination phase. So it deals with the different set of genes and also gene variations. So what is pharmacogenomics? It is the combination of genetic factors that each has contribution to population variability in drug action. A drug once administered has to go through different phases, and each phase is controlled by the genetic makeup of the individual. For example, a therapeutic dose could be an overdose in some and life-threatening in others. Okay, and understanding this concept and tailoring to patients' genetic makeup, administering a drug tailored to genetic makeup of the individual is known as personalized medicine. This, in fact, is an ongoing process in all other specialties like oncology, where it is widely applied. So let us go and let us see what its applications in anesthesia. To recap, once you administer drug, it has to go through variable phases like absorption, distribution, action on the target cells, and has to be metabolized before excretion. And that means it has to act through the pharmacokinetic and pharmacodynamic. These are the main two phases of once the drug enters the body, where body handles the drug and drug shows some results. And this pharmacokinetic and pharmacodynamic phase of the drug in the body is controlled by different set of genes. And depending on the genetic makeup of the individual, there will be a biological response and variability to drug action. So once again, the drug has to be gets absorbed, distributed, metabolized, and excretion. That is the pharmacokinetic phase. And the pharmacodynamic phase, it acts on the target receptors, and a lot of interactions are happening, and there is a signaling process, and depending on the finally there is a drug response, and each phase is controlled by the genetic makeup. So what is the advantage of understanding this concept? You can avoid guesswork and prescribe many very specific drugs tailored to this patient. And in anesthesia, the pharmacogenomics of opioids is the most widely studied aspect. It is shown that 30 to 70% of the individual variability among individuals for opioid requirement. It's a well-established fact. And one Indian study by Pankaj Kundra and et al. Showed the genetic polymorphism of opioid metabolism enzymes, receptors, and molecules in the pain pathway has been associated with the variability in opioid dose requirement in the Indian population. So coming to how it is going to affect at the molecular phase. In the pharmacokinetic phase, metabolism of opioids, as we know, it is mainly by the cytochrome set of superenzymes, cytochrome P450, and there are around 59 to 60 cytochrome enzymes which are which deals with anesthetic metabolism, and the significant ones for the opioids is cytochrome 2D6 and cytochrome 3A4. And genes encoding these enzymes show considerable variations, like that is known as polymorphism, and accordingly metabolism of opioids can be delayed or accelerated. So what is the clinical implications of this? That is, less than optimum cytochrome P2D6, that is known as poor metabolism, shows with opioid shows inadequate response. And these group of patients require higher dose or rescue analgesics, or you have to switch to alternate analgesics. That is the concept. Or you get another group of patients which have extensive metabolites, where there is a abundance cytochrome P2D6 level, and they are actively metabolizing, and there is a risk of developing respiratory depression even by tramadol and codeine. So these are two case reports wherein a child following tonsillectomy was given codeine for postoperative pain relief, and it was the anesthetist has prescribed the usual dose. These are not these are actually recent case reports, and the child has developed a respiratory arrest following usual dose of codeine. In another case, there was a case of respiratory depression with a child with ultra rapid metabolism after tramadol. So these are related to pharmacogenomics of the child, which was totally unexpected in the usual practice. Coming to pharmacodynamics, how the it can affect the opioid action. So we know that opioid mediated target is mu receptors, and there is the factors influencing the neurotransmitter pathways, that is catecholamine O methyl transferase can influence the opioid action on the mu receptors. And there are a lot of variations in the mu receptor gene. And the commonest single nucleotide polymorphism is alanine replaced by guanine, which is represented like that. And altered binding with, so this group of set of patients can show even the altered binding with even the endogenous beta endorphins and exogenous opioids. So they will have a variable response to pain therapy. So what is the clinical implications? You need 2 to 4 larger doses of alpha-dinyl concentration to produce same analgesia. I have quoted alpha-dinyl because that was the study conducted in this study article. And there is a 10 to 12 times higher doses to produce the same degree of respiratory depression in some patients. And they have noticed the increased morphine requirements with the variations in mu receptor gene. So that is the difference in the opioid action when you have a impaired genetic makeup in the target cells. So what about the pharmacogenomics of other anesthetic agents? I quoted mainly on opioids because they are the most widely studied. And animal studies have shown that pharmacogenomic variability to different intravenous and inhalation agents. And actually, there is a difficulty in identifying genes associated with anesthetic response in humans, probably due to incomplete understanding of the molecular mechanism of the anesthetic actions, mainly the IV and inhalation agents. What there are certain subunits studied, well understood, and that is the one is the epsilon subunit of GABA and cytochrome 2b6, where the propofol acts. And this group of patients there is an increased risk of developing propofol infusion syndrome. And malignant hyperthermia, it's a well-known entity, historically described as autosomal dominant, and there are around 50 mutations of ryanodine receptor is identified, and depending on that, patient can develop malignant hyperpyrexia. And children with variants with the methyl tetrahydrofluororeductase gene shows acute demyelination even with relatively short exposure to nitrous oxide. These are all well studied entities. So we go to other agents like propofol. Propofol with the genetic variant, you need higher dose requirement and higher levels of drug clearance and longer time needed for loss of consciousness and higher plasma concentrations. These we observe daily, but we may not go to the genetic makeup of that individual. A difference in propofol injection dose and variability in drug action is usually we observe in our day-to-day practice. So also for tyrosine, genetic variant of with the tyrosine can precipitate malignant hyperpyrexia with isoflurane. And another genetic variant, people show that with the fentanyl can cause median variation in effective dose requirement to achieve the analgesia. And with the suxamethonium, some of the agents cause delayed hydrolysis and increased duration of action, leading to prolonged neuromuscular blockade and apnea. And tendency for malignant hyperpyrexia I have with the ryanodine receptor gene, that's I have explained already. And these are these with even with acetopenin and NSAIDs also, there is these are all well studied aspects. So I just shown the graph. And now there is a rapid sequencing technology that's going to be the something in future, that is the predicting the risk of opioid addiction with the gene sequencing and dosing beta blockers, antiplatelets after acute coronary event. There are certain genetic makeups where beta blockers on antiplatelets won't act. And with the rapid sequencing technology, you can identify these patients and start optimize the dose of antiplatelets and beta blockers after acute coronary event, or even you can change the set of drugs. And there is a recent study for selecting appropriate antibiotics in severe sepsis, knowing that which group of individuals with a certain genetic makeup will respond to this your antibiotic. In a lighter note, you can also keep the DNA sequence of the patient and is predisposed to sue doctors in future. So this is something in coming up, and this is already there. And this is an Ambly chip. It is marketed by Roche Medicals, and you can actually look into the genetic makeup of the individual, whether they are ultra rapid metabolites, extensive metabolites, intermediate metabolites, or poor metabolites, and accordingly you can select the dose of drugs. This is mainly for opioids. Whether you want to give larger doses for ultra rapid metabolites or poor metabolites, you have to you can schedule like that. And this is the genetic profile of the individual. So this you can transfer to electronic health records. This shows ultra rapid metabolites, extensive metabolites. This set for one individual, which showing how the patient is likely to respond to opioids or other non-opioid analgesics, sedatives, antiemetics, beta blockers, muscle relaxant, any set of drugs, because there are limited set of drugs at present which are subjected to pharmacogenomic or pharmacogenetic profile. Once you achieve that, you can transfer it to electronic health records. You can keep it in the electronic health records, so that you can warn the health providers regarding genetic risk to medications in future prescriptions. So having known all these things, what is the limiting factor in transferring this knowledge into our day-to-day practice? And that is known as the translation of knowledge from the lab to clinical practice. That has to go through a lot of hurdles. Once you discover something, mainly the pharmacotechnology or pharmacotechnology or pharmaceutical industry, you have to get the proper research funding. You need government and non-government organizations to fund all these things. And you have to satisfy the requirements for the regulatory authorities, and you have to coordinate with the medical centers. Then only you have to go for the trial on this patient. You have to satisfy the physician to give the trial to the patient before it is subject. It is introduced into the market, but they have to get the approval of the insurance company and all. So from laboratory to bedside requires a large integrated effort, and it has got a lot of economic implications. Finally, you have to recoup the money you have to, the biotechnology company has invested from the market, and you need proper funding agents. And at present, there is the insurance cover for these patients for pharmacogenomic testing is it's not standardized. Some of the private players do cover that in for that also, but some don't pay for that. So you need an uniform policy which has to be initiated by the government. And there is a lot of medical legal implications in checking. You need to get the consent of the patient for storing in the hospital records. So what can you expect in future from pharmacogenomics? No one can predict the future, but we didn't expect the corona to come 2 years back. So we cannot really say that it's going to be the future or it is likely to be the future, but seeing the trajectory of events, it's very likely that it is going to come. So you can, the advantage is you can customize the drug therapy, You can actually screen the genetic markers in future in helping to predict the analgesic and or anesthetic dose requirement for the patient if it comes for subsequent surgery. And you can identify novel therapeutic targets for your research purpose. And another question is, when should and to whom should the genetic testing be performed? At present, FDA doesn't recommend testing pharmacogenomic biomarkers for all drugs, but they do recommend for codeine and tramadol, probably after the two incidents I have quoted, which was widely discussed in the medical fraternity in US. And with the pharmacogenomic testing, widespread pharmacogenomic testing, you can expect improved and more economical molecular technology, which can ultimately take a lead in quantity of a good quantity of pharmacological data. And you can actually risk stratify the patients who is likely to withstand the surgical trauma. That is, there are studies showing that the patient is coming out of coronary bypass surgery, and that also depends upon how these patients withstand their surgical stress, and the outcome finally depends upon to certain extent depends upon the genetic factors also. Though I agree that there are a lot of other factors too. And the genetic guided pharmacotherapy can complement the ERAS protocol, that is enhanced recovery in anesthesia after surgery. That's being widely discussed now, because everybody wants ERAS protocol so as to cut short the hospital stay and improve the patient satisfaction. So in conclusion, pharmacogenomics has the potential to increase the drug efficacy, eliminate the costly and alternative, and prevent drug toxicity. And genotyping may provide more clues to the etiology of condition that are with the suspicious anesthetic histories. That is, if you have a slow awakening or awareness in spite of keeping adequate MAC, or in spite of having the burst suppression in EEG, still you have patient complaining of awareness, you can subject this patient for genetic testing, and you can be a good research tool in future for a rational design of new drugs. So friends, if there is postgraduates listening to this talk, I'm sure that in the coming years, at least in the next 10 to 20 years, you will be seeing PAC and deciding the anesthesia of the patient depending on the barcode of the patient. But there will be something will be missing in the doctor to patient interaction. Thank you all for the patient listening. Over to Dr. Fijil. Dr. Fijil.
Thank you, Rajesh sir. It was a wonderful futuristic presentation. I myself have one doubt.
Yes.
Is there any place in Calicut or Kerala where we can do pharmacogenomic studies, or these are things which are in the pipeline and not to be done? I mean, not yet done in a clinical basis and only in the experimental phase. Is it like that?
As far as anesthesia goes, these are very limited applications, but it is applied extensively in oncomedicine.
Okay.
Oncomedicine, they do something similar to this very regularly, and accordingly they select each individual or each the patient has got a different protocol in place.
Okay.
But for anesthesia, even in the developed countries, there have a ongoing debate whether we should subject all anesthetic drugs to genetic profiling.
Okay.
But it is likely to come in the new decennium.
Fijil, I'm not promoting, but ICRA started that genetic sequencing lab. So this MH and all, they can detect early because of genomic sequencing. They started the lab. Mainly it's for nephrology.
Yeah, I have seen it, Dr. Venu. That is for onco and nephro patients, no? Hello?
Profile.
വെങ്കട്ടഗിരി സാറിന്റെ കാര്യം ചോദിക്കാനാ. Okay.
And since Dr. Venu has mentioned about it, Dr. Venu, are you online?
Yes.
Yeah, you have put up a post in the ISA City branch about keeping dantrolene.
Yeah.
And I have discussed with the chairman, and chairman has agreed to keep it so that once we keep it, we should let you know. But then how to keep it, I don't know whether the different hospitals has to, because it has got a short shelf life, and the cost is very expensive also. So how to keep it, I don't know, and how to share the cost also, I don't know, because like something like different one or two hospital has to share the cost. Like that.
Actually, my plan is to involving 3 or 4 hospitals. I already spoke to MIMS, Maitra, ICRA already agreed, and I think MCT also can do. So 5 hospitals, and along with the share of ISA, we can keep it in some hospital, and as and when needed, first dose at least 4 or 5 vials we can distribute to the patient. But meanwhile, we can arrange the second dose or much more if we need it, we can arrange it from other neighboring places. That's what I initially thought, but unfortunately I didn't unable to trace the particular person. So the drug actual pricing, present pricing, and I don't know actually.
12,500. I checked in the net.
11,000. How much?
12,500 for each vial.
So how many vials for a first dose?
At least 10
minimum
vials should be there, no?
10 vials. So 1.2 lakhs we have to mobilize,
yeah,
and 20,000 from every hospital. So already agreed for all these hospitals, because short half-life is shelf life is short, but still it will be life saving. And for neighboring areas, that is Kannur or Coimbatore, even I think Dr. Bharvagat is already keeping it in the Coimbatore, few vials, and Thrissur all will be beneficiaries.
If we can keep it in Calicut, it will be good. Dr. Sri Ganesh is there, professor of anesthesia, Mangalore. I have seen his comments in the chat box.
Yeah, but I have no experience on MH and the use of dantrolene, so I would not be able to comment on this. But it was an excellent presentation, Dr. Rajesh. Congratulations.
Thank you, sir.
Any more doubts or clarifications from anybody? None, I guess. So that concludes the first this thing. Let's hope in the future we'll be sending as part of our investigation genetic genomic sequencing also, and we can dose our drugs accordingly. We'll take a small break from the academic session because our ISA National President-elect Venkatagiri sir has joined this meeting. I would like to invite him for a brief address to the ISA City branch. Venkatagiri sir.
വിളിക്കേണ്ടി വരും. He was there. Mute ആണോ?
Mute ആണോ? We'll carry on with the academics then. Okay, now Dr. Vijesh, HOD Cardiac Anesthesia, KMCT, will be presenting a topic called Silver Tsunami. I googled what Silver Tsunami was. It shows something like it is early baby boomers. Other than that, to be honest, I also don't have much idea on what the class is all about. And I am very enthusiastic and eager to know what it is. Over to Vijesh.
Thank you, Dr. Fijal and Dr. Priyanka, for the invitation to talk on Silver Tsunami. So without any delay, I would like to go into the topic as such. So Silver Tsunami. So before going to the topic, I would like to just introduce the the agreed cutoff. Hello. I am audible, that's visible, right?
Yeah, you are visible and audible also.
Yeah, so we will continue. So the UN agreed cutoff for saying a patient is elderly is 60, age more than 60 years. So the population census and all will be based on the UN agreed cutoff of age of 60 years. Whereas the World Health Organization calls elderly more than 65 years. And within the elderly population, further classification like oldest old, that is normally those who are 80 plus, centenarian, that is 100 plus, and super centenarian, that is 110 plus. So you must now have got an idea of what is silver tsunami. I'll be talking about anesthesia for the elderly. The oldest man alive, according to the Guinness World Records, is Emilio Flores Marque, who is a retired sugarcane farmer from the Caribbean island of Puerto Rico. And as of June 30th, 2021, he was 112 years old and 326 days. If you look at, there are a lot of Indians who are elder than him, but unfortunately, we as Indians don't have the birth certificates. So the Guinness Book of World Records don't accept those claims. If you look at the Indian statistics, almost 9.78, that is almost 10% of our population belongs to the geriatric age group. So aging in India, we have around 2 lakh centenarians, that is 100 plus population, and an estimated 50 lakh of these people live alone. So from presently in 2000, where we had a population, geriatric population of around 7.6%, it is expected to go to 20.6% in 2050. So we would have around 300 million elderly people by the year 2050. That is almost close to the population of United States. Now, what about Kerala? Kerala is aging faster than the rest of India. Presently, we have an old age population of around 6.6 million people. And it is projected to reach 35% in 2050. And if you look at the district-wise distribution, Pathanamthitta has the maximum number of patients above the age of 60. And if you look at Calicut, we are having around 12% of the population in the geriatric age group. So we should all brace for a silver tsunami that is going to come to our operation theater. That is people with silver hair. Now, with increasing age, the incidence of surgery increases and the mortality is higher. However, age itself is not a disease process, but instead serves as a chance for developing age-related diseases. Inadequate preparation and cursory evaluation is unfortunately a commonplace, especially in a time-pressured environment, especially when we anesthetize these patients during an emergency setting. A review of emergency procedures in the elderly found a 65% incidence of correctable deficiencies, especially in blood volume, electrolyte imbalance, and oxygen delivery. Recent studies have shown that the mortality or morbidity rates for fit, healthy octogenarians are not significantly higher than those for a younger patient. The elderly patient poses a specific challenge for the anesthesiologist, whose role might extend from a perioperative physician to that of a palliative care provider. So with that brief introduction, what is regarding the decision to operate? Now, a decision whether to operate should be made at a consultant level. It should be a combined decision taking into confidence the patient, the patient's wishes, the family, and the multidisciplinary team that would be treating a geriatric patient, including the geriatrician. Now, this should be clearly documented, and surgeries should be undertaken which would improve the quality or the quantity of a patient's life. There is no place for heroic yet futile surgery. Only patients with competency and capacity can provide informed consent or refuse surgery. Appropriately trained staff using formal tests of cognitive function should only diagnose confusional states. There are many potentially reversible causes like sepsis, dehydration, electrolyte or metabolic imbalances, and hypoxia, which could be the cause of this confusional state. So it is often appropriate to discuss even the resuscitation status with the patient as well as his relatives. In the Western world, it's very important regarding surrogate decision making. Living wills and advance directives are documents of the patient's wishes, and that should be respected regarding resuscitation or further management of the patient. Now, sometimes the patient will be giving a power of attorney to a known person or a relative to do their decision making. Now, when such formal information is unavailable, it might be necessary for us to turn to relatives for making the assumption that the patient's decision or the relative's decision is in the best of the patient's interest. Unfortunately, this assumption is not always valid. So regarding age and anesthetic risk, advanced age is a consistent risk for morbidity and mortality associated with anesthesia because a lot of chronic diseases increases with aging. The increased risk is mostly likely due to the comorbidities, and there is no evidence that age by itself increases the perioperative risk. So there is now a concept of whether it is the chronologic age or the biologic age that is important. However, age-related physiologic decline with lack of functional reserve is the one that causes the problems. So if you look at this graph, you can see that the maximal organ function declines once you're beyond 50 years of age. And so there is a decrease in your functional reserve. However, what we do is we see whether the patient has a pre-op METs of more than 4, and if it is so, we take them up for surgery with the routine risk. But what is important is to note that there are a lot of comorbidities. If you look at this graph, there is the age of 71 to 80, the persons with more than 3 comorbidities is very high. So in the elderly, the number of comorbidities is very high. So if the patient has a combination of frailty with comorbidity and disability, that is difficulty or dependency in daily living, then this patient is definitely a high-risk patient for undergoing anesthesia. So if you look at this diagram, you can see that there is hypertension, cardiac failure, diabetes, arthrosis, vision loss, hearing loss, repeated falls, dementia, and coronary artery disease in these patients. And beyond 70 years, it is said that you could have up to 5 comorbidities. So it is the comorbidities which add to the risk of the patient. So briefly, we will run through the geriatric physiology. So what are the physiologic changes that happen in the, initially we'll take up the cardiovascular system. So coming to the cardiovascular system, you can see that there are beta receptors here. You can see this picture, you can see that there is norepinephrine which binds to the beta receptors and it then acts on the cardiomyocyte, causing a positive chronotropy, dromotropy, inotropy, and lucitropy. But what happens in the old age is that there is a decreased response to beta receptor stimulation. And this is not because of the decrease in the number of beta receptors. There is no downregulation of the beta receptors, but however, there is an intracellular coupling issue. So the feedback to the nervous system is that the norepinephrine is not enough. So in these patients, you see that there is an increase in the circulating levels of norepinephrine. And also these patients have a decreased response to stress. So there is a decrease in the maximum heart rate in these patients. Similarly, if you look at the arteries and the veins, you can see that there is atherosclerotic plaque deposition there. There is also stiffening of these arteries because of infiltration of connective tissue. And this leads to an increase in the systolic blood pressure. So these patients always have a systolic hypertension and there is an increase in the pulse pressure. And due to the increase in the circulating levels of norepinephrine, it is seen that these patients have an increase in the afterload. And this leads to left ventricular hypertrophy. Now, if you look at the heart in these patients, you can see that because of the LV hypertrophy, this myocardium is also, in the myocardium, there are changes like there is an increase in the connective tissue, and this leads to increased wall stiffness, and this leads to diastolic dysfunction. So if you look at the patient with a diastolic dysfunction, it is seen that these patients operate with higher left ventricular and diastolic pressure. Now, suppose these patients have had an MI, what happens is these patients operate at a higher left ventricular volume. So both these type of patients are at a high risk of developing pulmonary edema if you don't regulate the fluid, if you don't have a proper fluid management. And how do you diagnose diastolic dysfunction? It's by looking at the mitral inflow, where you find the E by A gradient, and you will find that the E is smaller than the A. Now coming to the autonomic nervous system, that is important because there is a decrease in the parasympathetic tone and an increase in the sympathetic tone, as well as there is a decrease in the baroreceptor responsiveness. So this leads to orthostatic hypotension. So you would have always seen the elderly people, once they get up from bed, they usually sit on the bed for some time so that they get back this, because they have experienced orthostatic hypotension. So what this does is, perioperatively, we have, because of this, you could get labile hemodynamics. Also, because of this autonomic instability, the thermoregulation is also affected. Now, if you look at the conduction system in the heart, you can see that the number of pacemaker cells in the SA node is reduced in elderly. So here the heart rate usually reduces by around 1 beat per year once you're above 40 years. Also, the SA node, the AV node, and the conduction bundles are infiltrated with fatty and fibrous tissue, and this leads to sick sinus syndrome and right bundle branch block. Also, these patients are more prone for developing atrial fibrillation because of the increased size of the LA, because of the associated diastolic dysfunction, which causes an increase in the LA size. So that is regarding the changes in the cardiovascular system. So what are the anesthetic implications for us? We have to identify the concomitant cardiovascular diseases, and we should not confuse it with the normal aging process. We should assess the functional reserve of the patient and identify frailty. Around 30% of patients have an abnormal pre-op ECG with increased cardiac dysrhythmias and conduction abnormalities. There is increased systolic blood pressure, there is decreased cardiac reserve and a stiff left ventricle. And elderly act as if we have given them beta blockers. Now coming to the respiratory system, you can see this picture here on the right side. You can see the age-related changes. If you go all the way down, you can see that there is decreased elastic fibers and increased cross-linkage of collagen. So what it does is decreases the elastic recoil of the lung, and thereby the lung does not deflate easily. There is an increased compliance of the lung as well as an increase in the functional residual capacity. And if you look at the alveoli, you can see that there is loss of alveolar units, and these alveolar units are all enlarged as an emphysematous chest. And because of this, there is a decrease in the oxygen diffusing capacity, and it leads to a decrease in the PaO2 of the patient. So you can predict the PaO2 of an elderly using the formula 109 minus 0.4 into age. So for a 60-year-old patient, you would expect the PaO2 to be a normal PaO2 to be around 80, and for an 80-year-old patient, you would expect a normal PaO2 to be around 60. And also you can see that there is an increased stiffness of the chest wall and there is decreased muscle mass, so they are not able to increase their ventilatory reserve. Also, there is reduced mucociliary clearance that leads to a reduced cough and pooling of secretions. Now, if you look at this diagram, you can see that the closing volume, the residual volume increases. The residual volume is the one which increases, and what it does is the FRC also increase, and along with it, the closing volume will increase. So in a patient who is erect and at the age of around 66, the closing volume crosses the FRC, and so these patients can have small airway closure and will lead to premature airway closure as well as ventilation perfusion mismatch. And by the age of 44, in an supine patient, by the age of 44, the closing volume crosses the FRC. So these are the age-related changes in the elderly. Similarly, there is a leftward shift of the oxyhemoglobin curve, so that reduces your P50. So the release of oxygen is also less. So the anesthetic implications are there is decreased ability to respond to induced hypercarbia or hypoxia, and there is potential for increased post-operative pulmonary complications. The decreased PaO2 preoperatively and a greater decreased post-operative period is there, so there is increased requirement of oxygen in the recovery and OR. And ventilation perfusion mismatch is aggravated by supine position and by administering general anesthesia. Now coming to the central nervous system, if you look at the central nervous system, if you look at this graph here, you can see that the cortical neuron density reduces, and along with it, there is a reduction of the cortical blood flow as well as the cerebral metabolic requirement of oxygen. And there is a shrinkage of the brain in the elderly. And however, if you look, the autoregulation is there. The autoregulation is normal in elderly patients. Another problem in the elderly is that the autonomic dysfunction, as I mentioned previously, and that causes perioperative BP instability and temperature thermoregulation issues. Similarly, the neurotransmitter levels are reduced, like serotonin, dopamine, acetylcholine. All these levels are reduced. So what happens is this leads to an increase in the sensitivity of anesthetic agents, and the minimum alveolar concentration is reduced by 6% every decade beyond 40 years. That means the same concentration of inhaled anesthetic will have a greater effect on the elderly than in the young. Now, if you extrapolate this 6% decrease, by the age of 137, your MAC would be 0. Another thing is there is a decrease in the pain perception, and you have to reduce the opioid dose by around 50%. And what we are more worried about is the postoperative cognitive dysfunction as well as the postoperative delirium. Postoperative cognitive dysfunction is diagnosed by cognitive tests, whereas postoperative delirium is a clinical diagnosis. So we'll deal with these later. Now, if you look at the changes in the renal system, you can see that as per the Cockcroft formula, the creatinine clearance has the component of age there. So there is a decrease in GFR and decrease in the tubular function, which leads to decrease in the concentration ability as well as diluting ability. And there is impaired handling of sodium and potassium. There is decreased ability to excrete hydrogen ions. So the anesthetic implications are there is a decreased ability to respond to physiologic stress. So we are predisposed, or the elderly are predisposed to prerenal azotemia, hyperkalemia. And because of the reduced clearance of the anesthetic drugs, this may contribute to a longer duration of action of these drugs. And suppose you have an elderly with a lower creatinine value, we should not be very happy because these patients have low muscle mass, which could be leading to the less creatinine in these patients. So any increase in creatinine in the elderly, it implies a greater decrement in the renal function than in the younger patients. Now, what about the liver? In the liver, there is a decrease in the hepatic blood flow as well as the liver size. Also, the production of albumin and the enzymes are reduced, and there is a decrease in the oxidative phase 1 metabolism. So what happens is the concentration of the drugs with high hepatic extraction ratios may be increased. And because of reduced albumin production, the dose of the anesthetic agents should be, which are protein bound, should be reduced. Now, coming to the thermoregulation in the elderly. Now, these patients are prone for both developing hypothermia as well as hyperthermia. Older patients have an increased risk of hypothermia because of an impaired ability to sense a colder temperature. They have less subcutaneous fat. There is impaired autonomic homeostasis. There is reduced heat generation due to a decline in the basal metabolic rate. There is reduced ability to increase their metabolic rate, and there is reduced ability to vasoconstrict and shiver. So these are the reasons why these patients are at an increased risk of hypothermia. Now, why they are at a risk of hyperthermia? Because the sweat gland function in the elderly is that there is reduced sweat gland output. These sweat glands will atrophy and they don't have, this output will be reduced. So these patients are prone for hyperthermia. Another issue is the skin blood flow. There is reduced skin blood flow in the elderly. So these patients are prone to hyperthermia because of these two reasons. So that is regarding the physiologic changes. Now coming to the pharmacologic aspects of aging, because most of these drugs, most of these patients or the elderly patients are on polypharmacy. So there is both change in the pharmacokinetics as well as the pharmacodynamics in the elderly. So if you look at the pharmacokinetics, all the phases are affected. That is both drug absorption, drug metabolism, drug excretion, and drug binding. All these are affected. If you look at their drug absorption right from the oropharynx to the esophagus, stomach, small intestine, colon, we have changes that lead to decreased absorption of drugs from these areas. Now, this is another chart which is showing you that absorption is reduced Similarly, if you look at the distribution, because of the decreased serum proteins, that is the decreased specifically albumin, the dose of protein-bound drugs should be reduced. So your intravenous anesthetic agent dose should be reduced. Similarly, there is an increased percentage of body fat. So what happens is, in these patients, this fat acts as a reservoir for the fat-soluble drugs, and this causes a delayed emergence. And another thing is, these patients have a decrease in the total body water. So there is a decrease in the volume of distribution of hydrophilic drugs. An example is muscle relaxants. So you should reduce the dose of muscle relaxants. So that is regarding distribution. Now, if you come to metabolism, as I have already told, there is a decreased cardiac output and decreased perfusion of liver where the drugs are metabolized. So there is accumulation and there is risk of drug toxicity. Similarly, excretion, there is decreased renal blood flow, and so there is a danger of accumulation and drug toxicity. So that should be kept in mind when you anesthetize these patients. Coming to pharmacodynamics, there is greater sensitivity to drugs based on these receptors and higher drug concentrations at CNS receptors. Now you can say that there is an increased sensitivity to the anesthetic gases because of the change in the neurotransmitters. However, the beta receptors, because of the internal coupling problem, they are less sensitive to your vasopressors and inotropes. So that is the pharmacodynamic action. Also, there are many pharmacodynamic interactions because these patients are on a polypharmacy. So we should be very careful because there are a lot of known interactions there. They could be on digoxin and furosemide, which can cause hypokalemia and increase risk for digitalis intoxication. Similarly, patients could be on nitroglycerin for their heart disease as well as sildenafil for sexual problems, and this can lead to an increased risk of severe hypotension. So all these interactions should be kept in mind. So for us, what is important is that you should reduce the inhaled volatile anesthetic agents. You should reduce the dose of your induction agents by around 15 to 50%, and benzodiazepines, they are known to cause postoperative delirium. So preferably you can avoid, and if at all you have to use it, you can reduce the dose by around 75%. Opioids, again, because of the increased sensitivity, you have to reduce the dose by around 50%. And neuromuscular blockers, as I said previously, because of the change in the volume of distribution, you have to preferably use shorter acting, and preferably you can use cis-attractive. So summarizing the physiologic changes, the severity of Crohn's disease is the primary contributor to the anesthetic risk rather than the age. Physiologic functional reserve to meet perioperative stresses is decreased, and drugs, we should reduce the dose and increase the dosing interval. Perioperative hemodynamic instability due to less baroreceptor activity, stiff myocardium, and greater swings in SVR. Fluids, excess volume not tolerated as veins are stiff, diastolic dysfunction of the heart, as well as there is risk of AF, or rather atrial fibrillation and stroke, and we should be aware of these patients are on polypharmacy. So geriatric patients are more vulnerable. Now, we should have a proper preoperative assessment. If you look at this patient, he looks very, very terrified that he is having to undergo a surgery. So we have to have a multidisciplinary approach to this. There is something called a comprehensive geriatric assessment with the help of the geriatricians too. So here you divide them into fit, vulnerable, and frail, and then decide upon the treatment. So if you spend some time with these patients, from that worried patient, you can have a happy geriatric patient undergoing anesthesia. So based on the preoperative assessment, you should take a proper history. So before that, you should know whether the patient has a proper cognition. So either you can do a mini mental state test or a mini cog, which can prove important in your postoperative period. Collateral history may be very important in these patients via relatives and nurses, and old anesthetic notes are also going to help you. So it's very important to know the cognitive function of the patient. And this is just a picture showing the choice of the patient, whether he requires Parkinsonism or Alzheimer's. So this is how a mini cog is done. A mini cog, this is a paper of a mini cog. There are 3 steps. There is a 3-word registration, a clock drawing, and a 3-word recall. So this can be adapted to the Indian version can be made, and this should be done so that we know what is the cognitive function of these elderly patients whom you are going to anesthetize. So what is done is in step 1 is you will say 3 words to the patient, and the patient will repeat those 3 words. And in step 2, he's asked to draw a clock, and he draws a clock with numbering them, and followed by you tell him to draw a time, something like 8:20 or 11:10. So he has to draw that properly. Now, if and the 4th step is to ask him what are the 3 words which we had asked. So these are the 4 steps of a mini cog. And if 3 words are recalled, he passes the test and with a normal clock. If only 1 or 2 words are recalled and he has an abnormal clock as shown here, he fails the test and he has to undergo a proper cognitive assessment. Similarly is the frailty score. We have the different types of frailty scores, like the Edmonton frailty score, which is researched score. But however, we can use this SWELL score, that is shrinkage, unintentional weight loss of more than 10 pounds per year, weakness, exhaustion, low physical activity, and slowness. If you have a score that is more than 4, that means this patient is definitely frail and is at a higher risk. There are certain specific points in the history which should ask, that is background to admission. Now, for example, suppose you have a patient with a fracture neck of femur. So we should make sure, we should ask him in the history what led to the fall, whether it is because of you slipped, whether it's a mechanical cause, or whether you had a visual problem, you couldn't see and you fell, or whether it was associated with a syncopal attack. Now, if it is associated with a syncopal attack, this elderly could be having aortic stenosis, and this could be a problem. Then there could be coexisting medical problems. Now, coexisting medical problems, the potential list is extremely long. You could have ischemic heart disease, hypertension, COPD, stroke, arthritis, dementia, Parkinsonism, malnutrition. Now, these patients could be using hearing aids or visual aids like spectacles. So that all we should make a note of. Similarly, you should should specifically ask for the dentition, whether he's having artificial dentures or not, and whether there is a history of gastroesophageal reflux disease, because this is very common in the elderly. Hiatus hernia and pharyngeal pouches are very common. Similarly, you should have a proper medication history, because all these patients are on polypharmacy. So the dose, frequency, and any recent changes, alcohol, smoking, all should be taken into account. So very important is to ask them whether they are on herbal medications. Because most of them are on that. So we have a lot of pharmacodynamic interactions that can happen. Examination, again, we should have a proper examination. Very important is to know what is the fluid balance of the patient, the weight, and the nutrition. They're all very important. Similarly, documentation of blood pressure, which will allow you an appropriate intraoperative management of hypotension. And you should always look for any unrecognized pathology. Like it could be highly relevant, such as a systolic murmur of aortic stenosis. And if possible, you should walk the ward or the stairs with the patient to assess real-time exercise tolerance. Now, there are few tests for which these patients undergo. There is a tug test. This is to know whether the patient has a more increased risk of falling. So this is important because when you mobilize the patient in the intensive care unit, if this patient does not pass the tug test, that means we should make sure that he has a competent relative to take care of him, or he has walking aids. So what this test is, the patient is asked to sit on a chair and then stand, walk 3 meters, turn around and walk back and sit. And if they cannot do it, normally it can be done in 12 seconds. The tug is nothing but timed up and go test. And if he takes more than 20 seconds, that means he definitely will have a history. He will postoperatively have a fall in the ICU when you try to have early mobilization of these patients. There are so many other tests like the 4-stage balance test as well as the 30-second chair test. So all these can be done. So at least the tug test can be done by us so that they can help the people in the intensive care. Now coming to the investigations, given the high incidence of comorbidities, an absolute minimum of ECG, blood full blood count, urea and electrolytes and blood sugar are required. Otherwise, you can investigate as clinically indicated. Age is not a barrier in itself for active tests like TMT or cardiopulmonary exercise testing. Intraoperative considerations. Now, very important is with an ASA 3 or above patients, both anesthetic and surgical staff should be adequately trained, supervised, and experienced. However, multiple retrospective and prospective studies have arrived at the same conclusion. There is no significant difference in outcome, which can be attributed or predominantly to the use of any specific agent, or no clear and objective benefit can be demonstrated for using regional rather than general anesthesia. So there are certain specific issues that we have to see in the intraoperative period, that is psychological preparation, appropriate pre-medication, and the patient should be pre-warned. IV access, adequate and accessible. It is potentially more difficult in elderly because of the dermoporosis and because of the lack of subcutaneous tissue. So whenever you try to prick, the vein can move around. Now, routinely you have to pre-oxygenate all these patients, because in these patients, once they are supine, FRC will exceed your closed capacity and there could be premature airway closure, leading to ventilation perfusion mismatch. Now, with IV induction agents, the arm brain circulation time is often increased and doses can be reduced if given slowly. So you should always ensure that it's a free flowing drip and have vasopressors on hand to manage the labile hemodynamics, which is accompanying these patients during induction. Now, airway maintenance is more difficult or hazardous in these patients because of osteoporotic mandibles. There could be loose tooth, there could be temporomandibular joint stiffness, there could be lax oropharyngeal muscle tone and edentulous jaws, cervical spondylosis, and arthritis of the atlanto-occipital joint. So you should be very careful when you intubate these patients, and airway management should be very done precisely. Sometimes it is best to leave dentures in place if it is a full set of dentures to provide support for face mask ventilation or laryngeal mask stability. There will be increased sensitivity to some agents such as volatile anesthetics, opioids, and benzodiazepines, but there is reduced sensitivity for others such as your inotropes and vasopressors, as I had mentioned previously. Now, if available, we should consider using short-acting agents like desflurane or sevoflurane because of the favorable low blood gas and tissue blood solubility coefficients that should result in a more rapid arousal, possibly in the early recovery period. Now, this is a regional anesthesia or general anesthesia. This is a debate that is going on, and it has not arrived at any conclusion because there are a lot of studies in literature. There are a lot of literature available, and the first one in the first study, again, DMJ Open, was done in 2018, which showed there was no benefit of patients, whether they underwent regional or general, on postoperative delirium. Whereas the second one from Korea, South Korea, showed that patients who underwent regional anesthesia had better outcome in patients, in elderly patients with hip fracture. And the third one, this is a very recent one, that is in 2020, which is a meta-analysis of randomized control trials comparing the efficacy of neuraxial versus general anesthesia in hip fracture surgery. Again, it did not show any difference between the two modalities except for reduced blood requirement in patients with who had neuraxial anesthesia. Now, a Cochrane review of hip surgery looked at 17 trials comparing GA to RA. It concluded that regional anesthesia might reduce mortality at 1 month, but the long-term mortality was unchanged. The proposed advantages include reduced thromboembolic events, reduced confusion, reduced postoperative respiratory problems, reduced endocrine stress response surgery, reduced blood loss, and advantages for monitoring in carotid or TURP surgery. Now, the issue with spinal anesthesia is if the level goes up, the heart rate contractility and peripheral vasoconstrictive compensative mechanisms are potentially reduced. And given the elderly who have already a reduced preload and LV contractility, you should be vigilant. So, eternal vigilance, which is our motto, should be applied there. Similarly, epidurals and spinals are technically more difficult in the elderly due to spondylosis, osteoarthritis, and there is difficulty in patient positioning. Very essential to maintain normothermia because hypothermia will impair your coagulation, immune function, and wound healing. So it is very important that you use these blankets or your fluid and blood warmers. Keep the temperature relatively warm, and in the ICU also use these bear huggers or the convective warming devices. And even the surgical wash, you can even use a warm surgical wash and IV fluids. Fluid management should be done absolutely properly in the intraoperative period because it's a tightrope walk. And meticulous positioning of these patients with the appropriate padding is very important because there is increased frequency of neuropraxia. And because of the fragile skin matrix and many bony protuberances, there is a chance of these patients developing pressure sores. So these are the points that we should keep in mind during the intraoperative period. Now, coming to the postoperative considerations, should always keep in mind that DVT prophylaxis, that should be done. Simple therapeutic options like giving good hydration, early mobilization, and giving him thromboembolic stockings are very important. Intraoperatively, you can use these calf compression devices, and also these patients can be on unfractionated or low molecular weight heparin to prevent DVT. Another thing is having a good nutrition to these patients, and here you should have the help of your relatives as well as the ancillary staff. And sugar monitoring again is very important because there is an increasing evidence for giving good glucose control, which would improve your patient outcome. Fluid management, as I said previously, it's a tight rope walk, and it's very important that you give the optimal fluid volume because it's a major contributory factor in the postoperative morbidity and mortality in the elderly. So acute renal failure, if you have a restrictive fluid protocol, there is an increased risk of the patient having an acute renal failure or shock and multiple organ failure. And if you give them liberal fluid because of the diastolic dysfunction, they could go in for pulmonary edema, as well as there could be poor wound healing. So if you look here, you should give the optimal fluid volume. Another thing is these patients, because of the reduced PaO2 preoperative, they require oxygen therapy. So we should be a little liberal in giving them oxygen. The elderly are less able to increase and maintain ventilation at high levels. So ventilatory muscle fatigue can occur early, but may not become apparent until 2 to 3 days postoperatively. Protective reflexes reduce with age, and so recurrent aspirations and pulmonary damage can be there. And because of these things, you should have a proper monitoring as well as you should be liberal with giving oxygen. Another very important thing is to have adequate postoperative pain control. Now, there are a lot of challenges now because there are myths that having pain is natural with aging. There are fears about addiction to pain medications. There is underreporting of pain, and there is a lack of congruence between the patient as well as the caregiver's perception of pain. And the caregiver may misinterpret the pain perception. So assessment of pain is a very important thing. It could be done by either using a pain thermometer. If the patient is not able to vocalize, you can use the Wong-Baker Faces pain rating, which the physician can do. Or in case of advanced dementia, you can use the PAIN-AD score. So what is more important is that once you decide on giving pain medication, you should always reassess frequently and adjust the management. So you can either employ the non-pharmacologic or low-risk pharmacologic managements, the non-pharmacologic like heat, physical therapy, the TENS, massage, acupuncture, or you could go in for the low-risk ones that are acetaminophen, or even patches where you can keep patches of NSAIDs, or you could consider interventional approaches like giving steroid injections, nerve blocks, radiofrequency denervation, or gabapentin, or opioids. But always reassess frequently and adjust the management. Rehabilitation, early mobilization is very important. Either you can give them good physiotherapy or occupational therapy, which will facilitate post-op recovery. And this is the most important thing, cognition. Elderly patients frequently experience deterioration in cognitive function in the post-operative period. So there are a lot of factors which have been identified. There are intraoperative aspects, post-operative aspects. Now, if you look at the intraoperative factors, there are not much you can control. Probably from transfusion onwards, blood pressure, glycemic control, or the depth of sedation. These are the ones which we can control, whereas the surgical aspect, the surgeon has to. Similarly, in the post-operative part, most of them, as anesthesiologists, we can address. So the perioperative or the intraoperative factors are maintaining a proper fluid status, intraoperative prevention of intraoperative hypo and hypertension, knowing the cerebral autoregulation limits, having a good blood glucose control, and preventing intraoperative hypoxia. And just like you have to monitor your temperature for detecting fever, similarly for detecting delirium, we should use some assessment tool. And what is commonly assessed is the confusion assessment method due to paucity of time. I'm not going into the details. In the ICU, you have a different CAM, that is confusion assessment method for the ICU, which includes the Richmond agitation sedation score into the scheme of things. So how do you prevent delirium? You should have early mobilization, optimized nutrition and hydration, have a proper medication review, give adequate pain relief, give good sleep to the patients, return him his hearing aids and eyeglasses, and minimize the restrained use. You can have the bystander along with the patient, and you can modify the anesthesia protocols as I mentioned previously. So what is important here is to have the Goldilocks principle, that is the Goldilocks anesthesia that is done. What it says is that the porridge, as Goldilocks in the fairy tale says, the porridge should be just right. That is the Goldilocks principle. It is the greatest proponent is Dr. Friedberg, and he says that measuring is better than guessing. Just because you have a patient, you should not give him too much sedation or too little. So you should give him just right. So you should have a brain monitor to monitor the anesthesia you're giving to these patients. But what is the evidence? There is insufficient evidence presently to make a recommendation. What about anesthetic agents? There is again insufficient evidence to recommend a specific anesthetic agent to reduce postoperative delirium, because there is similar rates between TIVA as well as volatile anesthetics, whether it is BIS-guided or not. Regional and neuroaxial techniques, again, there are a lot of RCTs going on. Probably we'll get an answer, but at present there is insufficient evidence. Regarding ICU sedation, there is an expert group recommendation that dexmedetomidine for postoperative dexmedetomidine sedation has shown to have less postoperative delirium in ICU patients when compared to lorazepam. So dexmedetomidine is an agent which you can use for sedation in the ICU. So you should have a team approach for preventing postoperative delirium. So I would like to summarize by saying that there is no ideal anesthetic for all elderly patients. Meticulous control of your physiological parameters is important. A thorough understanding of those physiological parameters will help you to optimize your anesthetic. And chronological age is much less important than an independent risk factor than emergency surgery. And a team of senior anesthetists, surgeons, and physicians need to be closely involved in the care of elderly patients who have poor physical status and high operative risk. Now, just a few more slides on elderly patients who underwent anesthesia and surgery. This is a 104-year-old woman who is thought to be the oldest patient in the world to have undergone a full hip replacement operation. But this record was broken by another lady who is 112 years. And most of these patients have fracture neck of femur because of their old age. And this is a 110-year-old woman who underwent hip replacement surgery at Chandigarh's Postgraduate Institute of Medical Education and Research very recently. And this is another elderly who was treated in Manjeri Medical College in Kerala's Malappuram district. She was a 110-year-old woman, Randathani Varyathu Pathu, who recovered from COVID, and she becomes the oldest patient in the state to recover from COVID. And very recently in 2021, a 118-year-old woman, Kartar Kaur Sangha, was given a pacemaker. However, the previous record was in Kerala, where a 114-year-old from Tirur was the oldest patient with a pacemaker. However, if you look at this report in the Saudi Journal of Anesthesia, the anesthetic management of a super centenarian, the oldest living person on earth. Unfortunately, all these Indian population, we don't have proper birth certificate and there is not proper documentation. So this is Dharampal Singh. He claimed to be the world's oldest marathon runner at 119 years. And at 122 years, he underwent emergency laparoscopy at Delhi's Army Hospital. Now, if you look at this concept of aging from Dr. Deepak Chopra, he says that there are steps where you can reverse aging. And his concept is that you can reverse aging by applying certain changes to your physical life, exercising and all that. And I would like to conclude by saying that these are two elderly patients going for the 70th birthday of their classmate, and this happens to be the 70th this geriatric person who unfortunately does not look like one. And more I see him, I start believing in Dr. Deepak Chopra's policy of reversal of aging, because this gentleman is 70 years old. Thank you, and always remember that elderly people are our asset, and International Elderly Day is on 1st of October. Thank you very much.
Thank you, Dr. Vijesh, for an interesting and exhaustive talk. I was actually expecting that elderly gentleman film star somewhere in the slide, and as expected, it came at the end. Any doubts from anybody, please?
Vijesh sir.
Yeah.
What would be the ideal sedating agent intraop, like for hip surgery patients? That's the most often I encountered. You said to not, preferably not to give benzodiazepines.
Yeah, so the benzodiazepines are definitely not to be given because it's an independent factor which can cause postoperative delirium. So presently, the recommendation is to go for dexmedetomidine. However, prophylactic dexmedetomidine has been found to have no effect on postoperative delirium. Like if you give dexmedetomidine intraoperatively, it is not shown to prevent postoperative delirium. There are studies on that. But because in the ICU, if you give dexmedetomidine, it is shown to reduce your incidence of postoperative delirium. So definitely, I think dexmedetomidine would be an ideal drug in during your neck of femur fracture patients.
So the problem with dexmed is most of our patients like having an ejection fraction of 20-25. So in those cases, using dexmed is a little difficult. That's why.
I use dexmed in all my cardiac patients who are having an ejection fraction of only 25.
Okay, you said you start with the bolus dose or
no,
just an infusion of 0.5 mg per.
Omit the bolus dose. Sorry, I didn't mention that.
Okay. Okay, sir. Okay. Thank you very much.
Like this was a huge topic. That is why it took a longer time. Actually, I did not even show the Deepak Chopra's video. There was a very good, I think it's available on YouTube, where he says that you can change. Then I checked whether how Deepak Chopra, how he looks right now. Actually, he has grown old, but Mammootty has not grown. So that is why I specifically put his picture.
If there are no more doubts, can we have the vote of thanks from Priyanka, please?
Thank you, Vijay sir. So I take this opportunity to thank ISA National President-elect Dr. Venkatagiri, Honorary President ISA Kerala Chapter Dr. EKM Abdul Nasir, Honorary Secretary ISA Kerala Chapter Dr. Biril Matthew for sparing their time out of the busy schedule for attending our meeting. And also I extend my heartfelt gratitude to Dr. Rajesh and Dr. Vijesh for their excellent presentations today. And last but not least of all, I would like to thank our ISA Calicut members for attending, ISA Calicut and the rest of the members for attending the meeting tonight. Thank you very much.
There are people from all over India. There are some people from even North India.
Yes, sir. Yes, sir. That's why I said other members also.
Not only Kerala, from outside Kerala also I saw 1 or 2 people who have logged in and seen this talk.
Yes.
Rajesh has given this talk. I heard in the Bangalore conference. So he told that because I could not, I was in theatre and continuing theatre, I could not hear it fully. Anyway, I'll be able to. Vijesh was good, that old, very old, what is that, centenarian, super centenarian, and all, lot of things to learn, Vijesh. And because I do a lot of geriatric cases, orthopedic, but knowing this is better for our practice. Very good. Thank you. Thank you. Nice.
Yes, sir.
Okay, then. Thank you, everybody. Let's wind up for the evening. Thank you all for the good
Okay.
presentation.
See you.
See you, sir.
Thanks.